My colleagues, thank you to the previous speakers for already giving you the gist of the topic. I'm not sure if I will be able to measure the dynamics of their presentations. I will keep it a bit more down to earth and will present some Czech data because I had clear instructions to speak about cost effectiveness of psychiatric pharmacotherapy in the context of the Czech reimbursement system. And I generally look at cost effectiveness or at economic aspects of health technologies, including medicines, and I believe that I have a certain insight in the Czech environment in this sense. I represent the Czech Technical University, and we have two working groups. We have CzechHTA Health Data Lab and then another working group. And the first group was created due to a collaboration with the Institute of Statistics. We have had an intense collaboration with them for 2 or 3 years, and we work with national data on healthcare services, and we have been using these data for HTA analysis so that we can follow the patient level, and we also want to make these data accessible for other scientific studies. So we anonymize these data so that even if a person looks at the patient level, they cannot actually tell who the person is. And this is my introductory slide showing that innovation in the field of psychedelics are not actually numerous. There haven't been so many new compounds, but esketamine does merit our attention, and I can mention the example of it entering the Czech market. It had to be approved and listed in the reimbursement system. Then there are other topics that resonate, and I understood them even though I am not a psychiatrist. These are depot forms that have to do with improved adherence of patients. Then another topic has to do with digitization of monitoring of medical use or observing patients and moving towards personalized or tailor-made procedures and treatments. Here is a slide I have been using for a long time to explain a simple principle, to explain how we view clinical benefits today. We can measure different things. We can measure the volume of a tumor. We can measure the number of metastases. We can carry out blood tests. But there has been this interoperable parameter, which is called subjective preference or utility of a certain procedure. And it is between 1 and 0, and it takes into account your health condition and whether it is good or not. Of course, 0 is the worst mark. Let's not speak about whether there are things worse than 0, but in this test, 0 means that nothing goes well, while 1 is the best mark, where everything is fine. This scale has also been used by economists because they have always looked at whether people were willing to pay for certain things. This can go for motorcycles or chocolate or maybe hiring a person who would mow your lawn. It's not important. It's always about using this same scale. So let's look at the trajectory of a person that spends 40 years in perfect health. And during this time, they will generate 40 QALYs, quality-adjusted life years. Then, if this person falls ill, they might spend 15 years as disabled, and then, of course, the quality of life is worse. So they will then generate 9 QALYs, and then later they will just generate 1.5 QALY during the last 5 years when they are bedridden. So during 60 years of life, they will not generate 60 QALYs, but rather 50 QALYs. And we are trying to take this into account while designing our treatment processes. This is the central concept underpinning these therapies, psychedelic-assisted therapies. And there are multiple methods of assessing this. 2 interesting methods are standard gamble and time trade-off. You can try them in practice because, for example, you can ask a person what risk they are willing to undergo. For example, if there is a treatment that has a 70% chance of complete recovery, but at the same time there is a 30% risk of death. And it is actually quite funny to ask these questions to people. We do it with students and we test it with different classrooms. And it is interesting to look at the results, but normally the range of answers is not that different, class from class. And basically you are looking at what risk you are willing to take in order to recover completely. Of course, if you are perfectly healthy, then you are not willing to risk anything. But if you are ill, then it makes sense. Then there is the other principle, the principle of time trade-off. And the question goes like this. How many years in perfect health would you be willing to live instead of 20 years in your current state of health? So these are games that people sometimes do. You can also imagine going to a football match, where you know that there is one person among those thousands, the 3,000 of football fans, and this one person wants to kill. So in this way you can obtain data and then transfer them, and of course it varies nation from nation. For example, you will have different results for France and for the Czech Republic, and you can then compare the data, and it is interesting to see what the results would be in your environment. If we look at the costs, we can distinguish between direct and indirect costs. On the one hand, we have direct costs that are covered by medical insurance or health insurance. This includes the medicines themselves, but also transport to hospital and so on. And then the more interesting thing is the indirect costs. These can be sometimes surprising for payers. These are costs that concern not only the patient, but also people around them. It is, for example, about people who start caring for their relative, and as a result, they cannot work. And right now, we work with different registers that have been linked to the social and economic registers that are created by our Ministry of Social Affairs, and they give us a more holistic perception of the whole thing. Because these indirect costs can have a major role. People end up disabled or even crippled, and this can lead to early retirements, which of course have economic impacts, for example, in the case of antipsychotics, but also in other domains. So all of these costs come together, and here I created a very simple scheme. You can have a patient undergoing psychotherapy and also pharmacotherapy, and the costs accumulate, and gradually they create indirect costs as well, because this person feels bad, then they don't go to work, then their parents feel bad, and so on and so forth. Oftentimes, innovative medicines are really costly, so they can represent the main part of the therapy at the beginning. And we can look at the scheme of between and after the therapy, and the question is whether we can scale the costs. It is interesting to look at different modalities that enter into this process. Let's now have a look at the situation in the Czech Republic. In terms of reimbursements, these are the data from our official statistic institute responsible for these data, and these are data concerning our health policy. And basically what it says is that we need to have an adequate comparator. For example, here I have listed a treatment A and a treatment B, and they all correspond to a certain number of QALYs. These are data that are required by this authority. So this analysis speaks of cost utility, and it works with QALYs, and you will divide the amount of crowns by the QALYs to see what is more cost effective. Right now, the Czech Republic has an implicit benchmark of 1.2 million per QALY. So if, for example, an innovation costs an extra 1 million crowns per QALY, it is likely to be approved in the Czech Republic. And for years, we have been kind of circling around this benchmark of 1.2 million Czech crowns. And the process starts with an application for approval. Then the procedure is being assessed, and its cost effectiveness is assessed as well. This is the most important aspect of the whole procedure. And of course, it is also assessed whether a certain substance is substitutable, whether it does meet an unmet need, and whether the landscape will have changed after 3 years when it is legal.
I will quickly through the example of esketamine. We have heard that in 2023 the procedure was launched. It continued with an invitation to supplement more data. That's quite common. The procedure is fairly interactive. Comments are submitted. The applicant is invited to provide more data. And in December of the subsequent year, a decision was issued and the maximum price was set. There were 2 different amounts. The basic amount was 4,357 Czech crowns. That was the maximum price. And reimbursement was set at 4,200. What's interesting? What was the development of the procedure? And this is quite typical. The discussion focused on comparators. What is the natural comparator? What would the patient receive? if at the time when it was decided that they should be getting esketamine, there would be no esketamine. And that's not a trivial question, and that was one of the main comments. Quetiapine was suggested by the applicant for standard treatment of depression. That was apparently not usual. That was a comment of the State Institute. That was resolved in cooperation with experts. Further negotiations followed. More models were created. And then the Institute accepted quetiapine as comparator, and that slightly raised the level of costs for the comparator, which is fairly crucial for the final result. And alternative scenarios were also added into the model. Some of you may know this. These are calculation models based on probability. The Markov model is the most common one. It plays with a certain period. It's usually quite a few years, usually 20 years, which is a fairly long time. And then the model uses cycles to simulate the scenario. And what comes out, apart from a number of other useful pieces of information, is the incremental cost-effectiveness ratio. And that's a figure which tells us how much the innovation will cost per one extra QALY. In the system where there is some therapy already, and the regulator takes that, thinks about how much they are willing to pay. Here it's 1.2, and you can see that it has gone way over. The drugs are expensive. And a miracle happened, and the treatment or the reimbursement was approved for various reasons. And they are all listed here. And this might be used as a guideline for the successful entry of other drugs on the market. First of all, it was expert support, clinical evidence, not only from the Czech Republic. As the conference has shown here, there is a lot of background. It's highly beneficial for clients, and the Experts Association was able to prove that. There's a lot of experience from abroad, and a risk-sharing agreement was entered into with the insurance company, and that's a significant factor. That means that the license holder made an agreement with the payer. There was probably some sort of ceiling or a cap for the payment, so that it did not affect the budget. And there was this unmet need aspect, which was acknowledged by the paying agency. So that was one of the examples of a possible market entry, although the area concerned was not on the preferred list. It wasn't oncology, for example. The Act does not really give preference to certain areas, but the decision is focused on the actual procedure, which I have described. And it's about the quality of life plus the calculations. Thank you very much for your attention.